Good morning, everyone. We're just waiting for the last of our guests to join us from the waiting room. And we're going to get it started right on time because our elder and knowledge keeper, Syexwáliya, is here with us this morning. And she's going to get us started in the right way with an opening, as she has done for most of our events for the last 4 years. Thank you to everyone who's joined us today for this opening session of the Clinical Research Ethics Symposium for 2022. And I'll now hand it over to Syexwáliya to give us an opening. Syexwáliya?
Thank you, Terry. It's amazing to hear that it's 4 years I've been doing this. Amazing. I'm really honored to be rejoining you again, Kayachton. When I raise my hands like this, I mean welcome this at this time. It also means thank you in our way. So Kayachton, I welcome each and every one of you to the ancestral traditional territories of Scohomish Okamail, where you're zooming into on my iPad and where you may be situated. And also honor, acknowledge my family at Tsleil-Waututh, Musqueam. Honor and acknowledge and respect the First Nations that you may be from, or your nations where you're from, and the territories where you live, work, and play. I raise my hands to you and just say thank you for Chenquin Mentomi. I'm grateful and thankful to all of you for letting me open you in a good way. And I just ask you to all come together in this symposium in Chomot and Syexwáliya in unity. And Chomot is unity, and Chomot and Syexwáliya is with one heart and one mind. To Chen Stwite, stand and work together to hold each other up and support one another because of the networks that get created, because maybe you'll connect through the chat, or maybe you know each other already. So just asking you to come together and be able to share all your different experiences, transfer knowledge, ask questions, and learn from each other. Because as my old people taught me, you never stop learning until the day you leave this earth. And that, you know, we all have something that we learn every day, and need to keep doing that and be able to spread that knowledge. I'm going to do Syexwáliya Slolum Hasqual greeting of the day. Then I'll do a prayer to start you off in a good way. And then I'll turn it back over to Terri. Oh, I always share that my grandfather, Syexwáliya, that's his ancestral name. My grandson, Chenaltsid, also carries the name Syexwáliya. And Dominic Charlie shared, we all have the inner energy. We have that energy, and if we believe in it, it can help us, and we receive energy from Creator through the top of our head into our inner energy. And we can send energy to each other and receive. And usually it's prayers for family and friends, or maybe it's messages that you, when you're connected closely with someone, if you think to them to contact you or something, and then they say, I have this feeling to call you. That's your inner energy and connection. Because Grandpa shared with me until he left this earth in 1972, he always shared, we're connected to everything, to each other, to the land, the earth, you know, the earth and all that's on it, and the air and water, and we're connected. And then I usually share, to make everyone relax, a story about bringing my children to see the first Star Wars movie in the 70s. And when Obi-Wan is teaching Luke about the Force, and when he was sharing, it was just like what my grandfather shared about our inner energy. And I said to my kids, that's what your great grandpa taught me, that we all have the inner energy, the Force. And so I became a Star Wars fan. And you can see I have my baby Grogu my R2D2, my old Yoda, and C3PO's here, and so is BB-8. And I have Legos that I took from my grandson when he got too old to have them anymore. I have Luke and Han and Darth Vader and stuff. So because of the inner energy, and I share that because when I'm culturally spiritual, I'm not a church person. I pray every day for my family, friends, and all on Mother Earth. And when we pray, we can't have our arms crossed, can't have our hands like this or this. We need to be open to receive and send energy. So I'm just going to ask you now to do some Tai Chi yoga, and you can all do downward dog to start. And then I'm just kidding. My elders say laughter is medicine. What I want you to do is open your hands and relax, have them in your lap, on your armchair, desk, whatever, but open, and send energy to each other. Prayers for the work you're gathered for, and prayers for your family, friends, and community. While I sing, pray for all of them. Chen Quen Mentomika Kakanak Chasiam Yonsion so Chinoyap and Manman Squalwan, the squalls to seats, Yonsio Manman, Equadal Chet Yap Squalwan, CII Chet Yap Squalwan, Okmail Chet Yap Squalwan. Asking you, Creator, to watch over all your children today and all of their family, Equadal Chet Yap, all of their friends, Yaya Chet Yap, all of their Ukmail Chet Yap, all of the village where they're originally from, and the villages where they now live, work, and play. Put a shield of safety and protection around each and every one of them, and help them all with their squalling feelings in their hearts and minds, their emotional, mental, physical, and spiritual health and well-being. Asking you, Creator, to help watch over and guide all your children today, and let them come together and Chomot and Squalwin, Chen Chen Stwite, to come together and be able to support one another and hold each other up and share all their different experiences and knowledge, transfer of knowledge, and be able to ask questions, to be able to create solutions for the present and future. Asking you, Creator, to watch over all our families from the unborn to the oldest, and help any who have illnesses or injuries and anxiety and depression. Help hear our prayers for their health, healing, and recovery. Hear our prayers for all of our family and friends who may have traumas and battle alcohol and drugs, whether it's prescription or toxic supply that's taking many, and hear our prayers for the homeless who are there because of their traumas and battles. And here are prayers for all of our family, friends, and communities who may have lost loved ones and have heavy feelings of sorrow in their heart, that our prayers hold them up as they say farewell to their loved ones going home to Creator, ancestors, and those who have gone before us, as well as in the healing days afterwards. And always remembering the teaching my grandfather taught me, that our loved ones worry about us who are left here to walk our life journey yet, and they watch over us. And I call them our spirit guardian warriors. And they make sure that we are protected as best they can, maybe by making sure we don't get as seriously injured or lose our lives in an accident. And we say, we were so lucky, we could have, been more hurt or lost our life in that accident. Spirit guardian warriors protecting you. Or you feel low in your squalling, and they'll send a sign, a hummingbird or an eagle, raven, something you don't normally see, and it lifts up your spirits, your squalling, your heart and mind. That's your spirit guardian warriors. So know you're always watched over and protected, and just be aware of the signs from now on. And asking you, Creator, to let today be a yet one halt's off, an excellent work today, with everyone coming together in Chomo and Squalwyn, with one heart and one mind, and to take care after the meeting and have a good weekend. Tama kwetsi snachum. Those are my words. Chen Quinn Mentomiop. I'm grateful and thankful to all of you for letting me join you. And as I always say, top left, my late son said peace and love, and he'd go top left over his heart. And I've added peace of heart and mind, love from my heart to your heart, air hugs. Wachayap yo, you all take care. Now I'll turn it over to Terri and say, have a great day, everyone.
Thank you very much, Syexwáliya. And I'm looking forward to when I get to see you again and actually have a real hug. So thank you very much, Syexwáliya, for starting us off right. And so I'd just like to remind everyone at this time that the session is being recorded for sharing afterwards. My name is Terri Fleming, and I'm joining you today with humility and gratitude from the traditional and unceded territory of the Lekwungen peoples, also known as the Wasanic, Esquimalt, and Songhees First Nations. And I welcome everyone to add to the chat their recognition and respect for the territories on which your homes or work happen on. And now I would like to hand it over to our moderator for the session today. Sarah Flann is a research ethics coordinator with the UBC Clinical Research Ethics Board. And prior to joining the CREB, she worked as the research ethics administrator at Fraser Health and Adler University. Sarah also has over 10 years of experience managing clinical neuroscience and neuroimaging research. Sarah was instrumental as a member of the advisory committee for the BC Ethics Harmonization Initiative. And so please take time to review all of the bios of our speakers for this session in the link. And I'm just going to ask a member of our team, thank you very much, to add the link. And I'm going to turn it over to Sarah now. Thank you, Sarah.
Thank you, Terri. Good morning, everyone. I'm very excited to be joining today from the traditional unceded homelands of the Kwantlen and Katzie First Nations. And thank you, Syexwáliya, for such a beautiful opening this morning. It was quite lovely and a great way to start our day. So we have a very exciting session to start off the symposium. We're going to be talking this morning about machine learning, artificial intelligence in clinical research, and as well as the ethical implications. And we have an all-star lineup to talk about that. But before we dive into the talks, I'm just going to let everyone know there is going to be a Slido link. So if you have questions, feel free to hit up Slido or the chat box. And we're going to have some time after each presentation for questions. And then at the end, we can have more time for some questions and a bit of discussion. So please interact with us. We're really looking forward to the talks and hearing what everybody thinks. We're going to start off today with Dr. Ehsan Karim, Assistant Professor in Health Data Science for the School and Population of Public Health at UBC, scientist for the Center of Health Evaluation and Outcome Sciences at St. Paul's Hospital, and Health Research BC Scholar Associate Member at UBC Statistics. And Dr. Karim is going to start us off talking about the use of large administrative data and machine learning in answering health research questions. So welcome.
Thank you, Sarah. Let me share the screen. Can we just confirm you can see the screen? Okay, thank you. Thanks for this nice introduction, Sarah, and thanks for inviting me for this talk. This is going to be a short talk, and I'm just going to talk about some of my own research about machine learning and some of the promises and pitfalls. So before I begin my talk, obviously, I want to acknowledge the land where I am today is the traditional, ancestral, and unceded territory of the Musqueam people. In terms of the outline of this talk, I'm basically going to talk about two things. The first is that, I'm going to outline an example of the use of machine learning and big data in comparative effectiveness study. Part of the reason is that I basically work in comparative effectiveness research in using tabular data. And then I will briefly mention some of the promises and pitfalls of the machine learning and big data uses. All right, so whenever we are talking about comparative effectiveness, obviously randomized clinical trial is the gold standard. And in randomized clinical trial in its simplest form, we generally randomize the patient groups to either treatment or the placebo groups. And we do have strict protocol, and we also apply strict eligibility criteria. And the reason we all love randomized clinical trial is because it eliminates bias in the treatment assignment, and also it permits us to use the probabilistic theories to identify what is the noise and what is the treatment effect. Right? So let us work with an example that I personally have worked on for some time now. This disease multiple sclerosis is relevant to British Columbia as well, from where I am. So this multiple sclerosis disease basically causes damage to nerve cell, and it causes frequent relapses. Over time, it can lead to disability, and there is no known cure for this. One of the treatments that are popularly used for this, for the management of the multiple sclerosis, is the beta interferon. And it is a treatment that requires regular injection, and it has side effects, and it is costly. But in the randomized clinical trials, it was shown that this beta interferon treatment is effective in reducing the relapse frequency. But if you look at the clinical trials that were used to approve the beta interferon treatments, most of those trials were limited to less than 5 years of follow-up. But if you look at the multiple sclerosis patients, this is a chronic disease where the patients are supposed to take the treatments for many, many years, right? So just getting the evidence from only 5 years may not be enough. And if we want to design a clinical trial for a longer period of time, like say, for example, 10, 20 years, that will require a huge amount of resources. The other aspect of randomized clinical trial is that we try to be careful about the eligibility criteria because of the safety concerns. And so most of the clinical trials generally do not include the patients over 50 years of old. But if a patient who is more than 50 years of old, whether they should take the beta interferon treatment or not is a question that cannot really be answered properly from a randomized clinical trial in that setting, right? So in those settings, we do need to rely on other sources other than the randomized clinical trials. And That's where we need to think of all of these other administrative data sources that we have available. So these administrative data sources could mean insurance claim data. There are other clinical registries. There are other clinical health records from the hospital, clinic, and regular practice that we can gather and link. So instead of having only 30 patients in a randomized clinical trial, we can now think about all of these data that are regularly collected for admin purposes and reuse those data to try to answer some of the questions that are hard to answer in a randomized clinical trial scenario. And obviously, these additional admin data are basically the found data or the observed data are something that reflects the real world clinical practice. And this is relatively cheap compared to a clinical trial, and it can be gathered relatively within a short amount of time, but the data can be messy. And since this is not a straightforward design how the data was generated, we need to consider careful analysis and design to make any interpretation from this particular type of data, right? So obviously we can work with our regular regression or parametric models, but given the characteristic of observed data, it will require a lot of assumptions, parametric assumptions, right? And to bypass some of those assumptions, we can rely on some of these non-parametric methods that are built. And as you can see from this particular graph, these machine learning methods or these non-parametric methods are getting popular every year. So everybody is super excited about machine learning methods, which are primarily geared toward prediction. And on top of that, there are softwares that are available nowadays that makes all of these technology very much accessible to any practitioners, right? So there is a lot of excitement about the machine learning methods and how we can apply them in the big data. All right, so one of the things that often is overlooked with all of this excitement about machine learning is that when we are talking about big data, obviously we're talking about large data. We're not talking about 30 patients or 50 patients. We're talking about thousands of patients maybe, right? And given the amount of data, sometimes we think that because we are dealing with big data, maybe we're dealing with everybody, but that's not necessarily true. We are obviously dealing with much larger data, but we need to carefully think about the representativeness, who is included in the data, who is left out from the data. And obviously there are some eligibility criteria that we need to think about very carefully. And correlation does not necessarily mean causation, even if that correlation is coming from a very big data. So understanding of the data generating process, like how the data was generated, how the data was collected, those are some of the most important aspects of trying to design a study based on this observed or found data whenever we are outside of this clinical trial realm. And whenever we are trying to do any kind of descriptive analysis, bypassing any expert opinion, say, for example, if I'm designing a study based on trying to understand the effect of a treatment on multiple sclerosis patients, and I'm leaving out any multiple sclerosis experts from designing the study, I'm not going to get very far outside of basically getting some descriptive analysis, right? But then again, we do have this machine learning methodology that are very powerful. We all know that. But then again, even if we are using all of this powerful technology in a data in a theory or assumption-free format, it does not always work well. One of the prime example for use of big data and machine learning fail is the Google flu trend. So at some point there was a huge excitement of this technology that was developed by Google about how to track the flu. But during this COVID-19, that technology has not been used because that technology has failed because of all of this assumption-free analysis that was done in that. So What I want to highlight from this particular slide is that we need to do well-designed study to be able to do any kind of analysis, and the quality of the data is very important. Just because we have the data does not necessarily mean that we have the best quality data, and the quality of the data matters when we're trying to interpret the analysis. All right, one of the recent example that I can cite about the failure of big data was that in the national health, NHS electronic health records from England, they used a data set of more than 17 million individuals, which is approximately more than 40% of England's adults. And they did the analysis of the factors associated with COVID-19 related death. But the problem was when they designed the study, it was a big data, that was fine, but the analysis goal was not clear, whether they were trying to do a descriptive study or a predictive study or a causal study. That was not necessarily clear. And as a byproduct of that, what happened is that this study got published in Nature, and various government entities interpreted the study differently because it was not clear what was the goal. And the way the study results were presented, it seemed like it was a causal analysis, and all of these different adjustments they have done were interpreted in an incorrect way. So just one example is that they were showing that the smokers were at less risk of death. And another example was that they showed that even if you have hypertension, you are at less risk. Eventually, there was a huge litigation against this in France, and the French government eventually admitted that they cited this particular paper where the study goal was not clear to make the policy about removing the hypertensive patients from the insurance coverage. So there are real world consequences of all of the analysis that we are doing. So the researchers need to take into consideration of these. Even if we are using powerful methods or big data, we need to pay attention to the design aspect very well. All right, so in terms of the analysis, we can always do prediction and causal inference. When I'm talking about causal inference, I'm basically talking about comparative effectiveness study. I'm talking about an outcome and maybe a treatment and the relationship between the outcome and the treatment, right? When we're trying to formulate a scientific question, obviously we need to understand the context and need to take input from the experts. But especially for the causal question, it is more important to take into consideration of the expert causal knowledge in trying to design the analysis, which is not as much of a factor when we are trying to analyze a predictive question. Just to give you an example, when we are trying to design a causal analysis, even though in a found data or an observed data, we get the data very quickly, we still need to follow through very rigorous process of how we can design the study very similar to the clinical trial. And there some of these target trial protocol that has been proposed can be very helpful in trying to mimic a randomized clinical trial, even though when we are using a big data or an observational study data. And obviously the machine learning methods can be a very flexible tool in analyzing, but before the analysis, it is very important to think about the design aspect of the study. Just to show one example from one of my papers that was published in American Journal of Epidemiology. Here, I am talking about the process by which the treatment is impacting the disability outcome. And obviously, this is a very complex process. Only relying on the data, we cannot really extract this type of information. We have to rely on the experts from the fields to combine with our data to get this kind of data generating process. And that will help us to design the study well. And once the study is designed, then we can think about how we can use machine learning methods to relax some of the stringent assumptions that we may need in a parametric model. And then we can think about machine learning methods or some of these double robust methods that are being very popular nowadays to think through how to properly analyze the data. And at the same time, we are not overfitting the data or not getting an analysis that are unstable. Right, and another use of machine learning in recent years, and this is a paper that I have worked on and was published in Epidemiology Journal, where we were working on found data or observational data, but there were some unmeasured confounding, which is a very common feature in observational studies of found data outside of the randomized clinical trial. And in that setting, we showed that when we are using large admin data, using the huge amount of information that we have from administrative data in the form of ICD-910 codes, we can try to reduce the amount of bias of unmeasured confounding when we are using those additional ICD-910 codes as proxy variables. And we can also enhance that method using the machine learning method. So with the combination of big data and machine learning method, we can try to reduce bias in the epidemiological study. All right. So just to summarize what I have been telling, the found data or observational data nowadays are becoming very cheap, and this is obviously more representative of the real world clinical practice. And this helps us do timely research. We do not need to wait for 10 years or 15 years to get our study results, even though we are working on a chronic disease. But one problem with this found data is that the design and analysis is much harder compared to a randomized clinical trial. So obviously, in the face of the availability of the big data and machine learning method, both of those aspects are very helpful in getting better results, but it does not necessarily mean that it is without the limitation. And if I can convey just one message, it's just that only machine learning tools are not necessarily enough. We need to take into consideration of the expert knowledge in order to design our study properly to be able to get any kind of meaningful results. And thank you.
Thank you, Sean. That was really interesting. I do have a question. I'm curious, you spoke about the representation of the data and who's included and who's not included. I'm just curious if you noticed or if there's any literature on differences between different healthcare systems. I'm thinking kind of if we want to just do something close to home, like the differences between perhaps Canada with universal healthcare versus the United States, where they've got like fees for service. Would Canadian data perhaps be more representative just because more people have access to the healthcare, which would in turn be in the administrative databases?
Yes, you are absolutely right. It obviously depends on the context, and just the example that you have cited in the Canadian context where we have universal healthcare, in that type of setting, we will probably capture more people compared to other situations where the data is probably not coming from the one unified system. The other issue is that when we do not have a universal system, we still have data that are coming from different insurance companies maybe. And then we need to consider who can be part of those insurance systems and who cannot be part of those insurance systems to be able to make any meaningful interpretation. So what is our target population and what are the samples that we are collecting? We need to be able to connect those and bridge those before we make any kind of interpretation or generalization.
Okay, so oh, here we have another question. Thank you for your answer for there. So we've got one from an ethics board review perspective. How can issues of inclusiveness of data be identified prior to the research being undertaken?
One thing I should probably acknowledge right off the bat is ethics is not my field of expertise. But then again, if we are trying to think about inclusiveness, that is somewhat a bit different question than the sample that we have at our hand. So obviously we can have a target population and we can have a sample, and in our sample, we may not have all of the representations, right? Then we need to be able to carefully think about, like, say, for example, if we do not have access to certain population, and then we simply do not have access to that population, we cannot be able to make any interpretation of those population based on the data that we have at hand. So one of the dangers of trying to make overgeneralization is that when we are trying to have a restricted population based on which we are doing the analysis, and then we are trying to generalize it to all population, we need to be very careful about that type of generalization, and we need to be careful about the people who are included versus the people who are not included, whether the characteristic of those population are similar or not, for us to be able to make that generalization.
So perhaps having experts like yourself review some of the analysis plans and whatnot might help at the ethics review stage, would you think? Or
I think it kind of depends on the context. So say, for example, if you are dealing with a particular disease context, maybe it is a very good idea to include some of the clinicians or the experts about the disease to understand better about who is probably included in that data that might be and whether that data is representative of the population about which we are trying to make our generalization, right? And if generalization is the goal, we need to be able to understand, like, what are the tools that we have at our hand and whether we are making over promises or not.
thank you. Maybe from a policy perspective, are there, when you think about BC data and our healthcare system that you've worked with, are there kind of suggestions you'd have for things that could be done to make our tools better in BC so the found data might be better or more representative? Or
Yeah, obviously we have a great system at BC. Nothing to complain here, but it's just that sometimes it takes time to get access to the data. So
better access is one thing. Okay.
Yeah.
Thank you. We've got another question on the Slido. What happens inside the artificial intelligence is a black box we often can't understand. Are there ways to make machine learning processes more understandable or transparent?
Obviously, there is a lot of research that are happening about this transparency of some of these machine learning methods that we are using. But as a teacher, when I teach to my students in the class, I generally try to start from the very basic. So instead of using a black box machine learning method, I say, for example, in the class, I try to first teach a very basic method that could give us a very simplistic answer. And going step by step from that simplistic process to the black box process, people then can understand, or researchers then can understand what are the ways or processes that are necessary to go from the simpler method to the black box method. So the only thing that I would suggest that the people who do not understand the black box method maybe try to collaborate with some people who may have a better understanding of the black box methods. Just because we have all of these softwares available, it is very much accessible for almost anybody to do a very complex analysis very fast. But when we are trying to interpret, we need to be able to collaborate with experts to have a better understanding of what we are dealing with.
That makes sense. Thank you. So we don't have any more questions for now, but if anyone thinks of anything later, there's going to be more opportunities to ask questions of Ehsan. Thank you so much. That was a very interesting presentation.
Thank you.
So our next speaker, Dr. Anita Ho, is a clinical associate professor for the Center of Applied Ethics at UBC, associate professor at UCSF Bioethics, scientist at the Center for Health Evaluation and Outcome Scientists, regional director of ethics in Northern California, and Providence St. Joseph Health elected fellow at the Hastings Center. And Dr. Ho is going to talk to us this morning about ethical AI to promote human-centered healthcare. Welcome, Dr. Ho.
Thank you so much. I really appreciate this opportunity. Can everybody hear me? Okay. Thank you. Let me just go from the start here. Okay. And I also want to thank Dr. Karim's presentation. It actually reminds me of some of the conversations that we had last year at this conference as well. And so if there is time, I may actually try to see how I may be able to bring some of the conversations from last year to Dr. Karim's presentation, particularly in relation to the question that just came about on issues about inclusiveness of some of the data sets. And it was also really interesting to hear some of Dr. Karim's work. And so I wonder if it would be possible for those who are on this call, like if you are working on machine learning models, if you're willing to share, perhaps you can put in your chat box too, in terms of what kinds of project you're doing, what type of models you are developing. Perhaps that may be a way for us to also think about potential collaborations among some of the participants as well. And that may also help us to, as we go along today, to think about what may be some of the ethical questions that come about that we may be able to address as well. So I would also like to respectfully and humbly acknowledge the lens I'm on, where I learn, where I also work. You see two different photos here on the left. Probably many of you who are living in British Columbia or Vancouver would recognize it as Stanley Park. So I do want to acknowledge that much of my learning has been taking part on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. But I'm currently today on the ancestral land of the Coast, Miwok, Pomo, and Wapo people in Northern California. So the photo on the right is a picture of the Armstrong Redwood Forest, which is in Sonoma County, which is where I'm today. I also want to acknowledge that a big part of my presentation today is being informed by an embedded ethics project that I'm working on with Dr. Martin McEwen. This is a CIHR funded project on using computer vision for monitoring Parkinson's disease progression. This demonstration here on the right is showing the use of computer vision to try to track users' motion, mobility, facial expression, to try to predict how people's progression may go. So if there is time, I may come back to this as well to think about what would a human-centered approach look like when we're thinking about developing these technologies. And this presentation is also informed by my forthcoming book, which is currently in production, Live Like Nobody's Watching, Relational Autonomy in the Age of Artificial Intelligence Health Monitoring. So that really ties to the task I was given for today, which is to talk about some broad ethical considerations for developing AI for human-centered care. In that book, I talk about 3 different use cases in using AI for health monitoring: home health monitoring, direct-to-consumer AI health apps, as well as medication adherence monitoring. So part of what I have been thinking about too is those use cases and how we think about human-centered care using artificial intelligence is to really think about how or why are we actually developing some of these models in the first place? What exactly are some of the questions that we are trying to answer? One example that had come to me quite a few times, partly because of apps, or I should say algorithms that I have seen, as well as discussions with my clinical colleagues, is the use of artificial intelligence to try to predict and identify patients who may skip appointments. So these are the so-called no-show algorithms. And one of the questions I want all of us to be thinking a little bit about throughout the next 20 minutes is, what do you think a human-centered approach would look like? How would that inform if we were to be developing AI algorithms for no-show appointments? So in this article, this is from 2019 in the newspaper Guardian. It's basically a UK study looking at MRI scan appointments to see which patients may or may not come to their appointments. So the algorithm used data sets looking at the time of day of the appointments, number of previous scans that the patient might have, and how far the patient lives from the hospital. Interestingly, the data that they included in developing the algorithm did not include gender, did not include age or ethnicity of these patients. It also is partly because of how they're trying to develop an algorithm that will work with the existing IT infrastructure for these particular hospitals. So that may be a question to ask, and tying to what Dr. Karim talked about is, what kind of data do we actually want to include when we are producing various or developing various kinds of algorithms to make sure that they actually are going to be accurate and useful actually for those whom you are targeting. But I do want us to keep in mind to think about what would that mean. So in terms of what data we include when we are thinking about what kind of model would be most human-centered. What exactly is our goal? Is our goal specifically to simply identify who may not be coming to the appointment, and so that we may double book and to make sure that if there may be somebody who doesn't show up, that there would be another patient who's taking the slot? Or is it going to be for encouraging or facilitating patients who otherwise may be missing appointments to be able to come to the appointments? And I'll come back to this example later today. So I think that this may be an example for us to really think about how do we develop or think through human-centered healthcare. As you can see in the picture on the right here, human-centered healthcare is really starting from the fundamental human needs. And so we are designing the care processes, whether it's the physical products that we're using, like devices we're using, the services that we are providing, the procedures, the strategies, and the policies will all be centering around the person. Now, but the person may be not just a patient, maybe also the patient's caregivers in the family, in the community, or clinicians as well. So the idea is that we will be designing or redesigning care processes to really fit with the people whom you're interacting with. So part of the question is really, how may the care affect stakeholders, care relationships, and also care expectations in various kinds of ways? So in general, we are often thinking about using AI for these purposes because of the hopes that AI would be able to help produce more higher value care, democratize information, and also from a more justice perspective, produce more equitable care. So for higher value care, there is assumption or at least hope that the use of AI with big data can allow us to have more precision that's more tailored to a particular patient's care, that can hopefully allow us to have faster, more accurate diagnoses that can perhaps facilitate preventive care and also help to promote patients being able to seek the right care at the right time. So it may also mean that patients will only go to the physicians, for example, when it is necessary, but making sure that they will get there when it is necessary. This may be also, there is a hope of democratizing health information. The use of AI, particularly when we make that information more available to patients and their care teams, is to say this is your data, so that hopefully that you can access it as you see fit, especially when you are trying to plan for your own care pathway. It may also allow, promote more equitable care, particularly if we can use some of these technologies in places where they may be more remote and may have less specialists as well. So this may also be allowing people who otherwise would not have access to these services to be able to access them when they need it. And so this is also partly why there are many people who are also pushing for direct-to-consumer artificial intelligence, thinking that that may be more human-centered because people can decide where they may actually receive the information and make care plans. But there may also be cautionary tales, and I think that Dr. Karim also kind of pointed out some of that as well. During COVID, hundreds of AI tools have been built to try to catch COVID or try to predict which patient with COVID may have more severe symptoms. One of the studies in the British Medical Journal looked at more than 230 algorithms for diagnosing patients with COVID and predicting the severity of the symptoms. But what they found was that actually none of them was fitting for clinical use. They found that there were 2 that may be promising enough for further testing, but at the end of the day, a lot of resources have been put in building these models, but that they have not been able to be used at the clinical setting yet. So this really raises various kinds of concerns, especially when we think about how much resource we are putting in AI development. Some of the potential concerns, I think, are more justice related as well. So when we think about human-centered care and using AI to promote human-centered care, we still need to center ourselves back into various bioethical and research ethics principles about how do we respect persons, making sure that what we are developing, technology or processes, are going to be promoting people's well-being, not harming them any further, and also promote justice. But there may be questions, particularly in relation to respect for persons, whether patients are actually ready for some of these technologies, and whether clinicians are willing or feel that they are actually equipped to also be engaging with these technologies as well. There are also questions from a broader justice perspective in terms of whether the healthcare and research systems themselves are fragmented. Dr. Karim was very kind to, I think, the BC system in terms of whether or how we are able to access data. But even time, when we don't have timely data, sometimes that may actually also mean that we are perhaps always a step behind, especially when we're in a pandemic or kind of emergency situations. So sometimes when we don't have the robust, timely, or complete data, there may also be questions in terms of whether we are able to do validity testing for different populations as well. There are also broader justice questions in terms of, do we have the digital infrastructure for people who may be living in remote areas? So we think that perhaps these technologies can help to promote human-centered care in places that have less resources. But we're not just talking about resources for clinicians. We're also talking about very basic infrastructure resources. There may also be resource questions in terms of whether different hospitals are using operational systems or EMR systems that actually are speaking to each other, because otherwise, even when we are taking data sets from different places, we may not even be able to really merge the data when they are not interoperational. So the example that I was mentioning at the beginning about the no-show is that actually there might be a lot of data that could have been helpful looking at people's gender, which may sometimes indicate certain responsibilities that people may have outside of their own work responsibilities. Maybe there are other family responsibilities that we may be missing in terms of how that may contribute to people's ability to actually make it to the appointments. But sometimes when we're trying to fit what the IT infrastructure is, we may be missing other very important information. There may also be questions in terms of whether sometimes these narrow AI models are very good, for example, in reading images, but it doesn't necessarily answer all the other questions in terms of how patients may experience their particular diagnosis. It may also not tell us other social determinants of health that may also be more important than what an AI may be able to tell us. So when we think about human-centered care, we have to really think about how do patients experience their illnesses, experience their health concerns, and care delivery in a much broader setting. So in thinking about AI for human-centered healthcare, we need to go beyond even also just accuracy or technological feasibility. They are certainly very important. So that's why having accurate or complete data would be important. But when we think about human-centered healthcare, it's also about what is actually humanly desirable for those who are within this ecosystem, so that we can address their concerns in a real-world healthcare setting. This also means that we have to be concerned about clinicians' own needs as well as their expectations and experiences. So for example, EMR for many people has really made healthcare data much more easy to access, but for some clinicians, using EMR also means a lot more administrative work. Some studies have shown that, for example, for primary care physicians that they spend 2 hours on EMR-related tasks for every hour of direct patient care. So how do we actually navigate some of these different needs as well for the different humans that may be part of the system? And how may patients or families and the communities where they live in have different kinds of expectations when we may be using various types of AI? So for example, when patients are getting immediate information, we may think that can promote patients' autonomy and well-being. There may be questions in terms of whether patients and the family caregivers are now also expecting that they would be able to also have follow-up care right away. So if we don't have a healthcare system that is actually facilitating people to have follow-up care, just because we have good predictive system does not necessarily promote human-centered healthcare. There are also questions that we have to think about also from a research ethics perspective as well, which is that a lot of the AI systems is not just delivering various kinds of predictions and services, but that it may also be continuously collecting and further analyzing the real-time data. So there are questions in terms of whether users will be accepting their data being continuously used and possibly being shared with other entities. So the picture, the screenshot on the right is a suicide hotline chat bot that allows people to get some information about mental health or answer questions regarding suicidal ideations. But there certainly have been questions in terms of whether people are willing to have their information that they are putting into the chat to be shared with other for-profit entities, even if these entities may actually be thinking that they could promote or develop better or more accurate algorithms later on. So certainly when we think about human-centered healthcare and the use of AI in building such care, that there are many other kinds of considerations that we have to think about. So I think that there may be 4 general questions that we can be focusing on when we try to develop AI for human-centered care. I think the first one that we really want to think about is whether the research question is actually the right one to begin with, and whether this is really a problem that can be solved by using AI, or are there other things that actually may be better to solve that issue? So what outcomes do we think that the AI can provide us? And are there actions that we can actually do to address this issue? Are there other technologies that may be better situated to address these problems based on the resources that we have, based on the communities that we're working with, and so on? So some of these questions we can't answer unless we are engaging with the stakeholders from the very beginning, even informing the research questions, asking questions about who will be affected by the use and development of these technologies, and how may they be affected. Are they or how may they be involved in the design, development, evaluation, the validation, and the implementation of the models? So sometimes even good tools may not be used because clinicians are not equipped. They cannot actually build that into the regular workflow. So if it is being used in a way that is adding to people's workflow without necessarily giving clinicians an actionable response, then there may be questions also from the resource allocation question, whether this is feasible. Piggybacking on what Dr. Karim talked about, we also need to think about the data sources that we have. Are they representative? Are they complete? As I mentioned, with the no-show algorithm, there may be certain types of data that are actually very relevant and important to how people actually engage with their appointment system that may be missing. So could there be biases? And depending on what a hospital's electronic record system looks like, there may also be other kinds of missing data, especially when we are transitioning from one system to another. So how may we be able to mend those gaps as well? I also think that we need to really think about the usability and feasibility at every level of the way. So at the more bedside, micro level, how might individual patients, clinicians deal with or use these technologies? but also at an institutional level, whether it's at your particular unit, your hospital, your clinic level. How may that also affect the macro level considerations as well? So there may be, as I mentioned, questions about clinical workflow. Is it really workable? And is the information that is being provided by these systems also going to be integrated back into the electronic health record to promote better care in the future as well? So one of the questions why I asked whether sometimes we really need to first ask whether this is the best tool that we have is that there are maybe times that when we are developing algorithms that actually are not necessary because clinicians may actually already be very good in identifying those questions. So this article talks about an algorithm that is being used in Northern California, among other places, of identifying patients who may be dying within a year. The idea is that it will prompt clinicians to start these end-of-life conversations with patients. And interestingly, this particular algorithm that the developers saw is a success because it can identify high-risk patients. High-risk patients are the ones who would likely benefit from advanced care planning and will likely die within 6 months of this time. The algorithm correctly identified about 51% of these high-risk patients and also identified about 65% of the mid-risk patients. These are patients who would likely die within 18 months. And they identified about 4% of the patients who may have a lower risk of dying. So the algorithm apparently did increase the engagement of clinicians in end-of-life care planning with patients by about 75%. Now, when I read the article, I actually thought, is that a success or not? Or do we need this tool? I thought 51% of identifying high-risk patient is almost like a coin toss. So I wasn't really quite clear why that was identified as showing that this tool is particularly successful. And there may also be questions in terms of whether there are other ways of also encouraging end-of-life care conversations that may not require the algorithm. I'm not arguing against using algorithm. I'm basically raising questions in terms of when do we think algorithms are most helpful and when do we think that there may be other kinds of resources we want to use. If it is a binary kind of decision, just like do we want to use artificial intelligence to identify how people are progressing with the Parkinson's versus you will have more visits to your neurologist or your neurology team, how would people choose between binary decisions? Versus we are actually providing people multiple options. So in closing, I would recommend that we are recentering the bioethical and research ethics principles that I mentioned earlier about respect for persons, ensuring that what we are doing is really focusing on people's well-being and reducing harm, and also think about the whole ecosystem and thinking about justice and equity. That would help us to really think about how do we design with our stakeholders rather than for the stakeholders. Recognizing the developers and those who are the end users may not always share the same kind of experiences and expectations. So with the community engagement, this may help us to really make sure that we are analyzing the utility of these tools in the real world setting. Do we really have actionable output that would make this really helpful? Would this actually impact patient outcomes in the ways that really matter to patients and to the clinicians? And will the solution be implemented at the point of care in the right kind of way? So really thinking about more of a system analysis, not just looking at one particular situation at a time. So I think that sometimes when we think about democratizing information, the use of AI to give people more information, whether clinicians or patients, we also have to be careful that sometimes giving more information, more predictions are not always going to be human-centered. This New York Times article from a few weeks ago talked about how now for many people, this one came from the US, you can now look at your medical test results, often even before you talk to your clinicians. But if this information is given to people without interpretation, without understanding of the bigger context, sometimes it may actually scare people more or confuse them more than anything else. Dr. Karim mentioned earlier about how in Canada, we're in a tax-funded healthcare system. There may also then be questions, I think ethical questions, which we have learned from direct-to-consumer genetic tests as well, whether sometimes that some of these devices or algorithms, especially if they're commercially developed and disseminated, may somehow give people information that may or may not be useful, and that in the end, get patients to come back to the healthcare system to seek further tests or further consultation that may put more of the burden back on the system as well. So I think there are take-home messages that technology is only a tool. It's not value-free. It's also not free from a monetary perspective. So we need to really think about whether this technology that we want to develop is really the best solution to promote human-centered care. Are there other ways to actually enhance human-centered care? Are we using the tools to replace human care? And how may those who are most affected actually think about that? So I think that if we are really trying to think about using technologies to enhance human-centered care, then we really need to refocus on the humans as well as the human systems, how they may be affected, and designing AI or other kinds of delivery system to really fit with the people. And I think the most importantly, to really think about how do we ensure that these systems are not going to be negatively affecting care relationships and the meanings of care. Thank you.
Thank you, Dr. Ho. That was fascinating. We do have a question from Slido here. It says, are there ways to determine appropriate size and characteristics of a data set for machine learning models to properly ethically analyze and answer research questions?
I think that Dr. Karim might be a better person in answering some of that. But I think that basically what, in a very broad sense, right? So what size, I'm not a statistician, so I won't be able to do that kind of calculation there. But we really, I think one thing about representativeness of data is really to see, you can have a lot more people in your data set, but that they're not representing the populations that you want to use that tool for. And so I think that we need to actually think even much broader questions. And so how do we make sure that who you are using the data set that you're using to develop the machine learning is actually the same people that you are going to be using the tool for? And are you validating your tools with the populations in mind? Do you give yourself some kind of, some people may call it a silent audit, right? That you may want to actually test that in the setting for a few months first before you know whether it is actually going to be appropriate for prime time.
Thank you. And just going back to some of the things you touched upon in your presentation, I've always kind of thought of using machine learning as more kind of to complement, you know, clinicians and help more than replace. I'm just curious if in your work you've come across kind of feelings from clinicians on the use of AI in healthcare.
Mm-hmm. Yeah, so I mean, maybe I can mention a little bit about the CIHR funded project that we're working on, that I'm part of that ethics project. So really looking at how can we use computer vision to detect Parkinson's disease progression. One of the reasons for developing these tools is because in Canada, patients have relatively infrequent visits to the neurologist. So these are patients with Parkinson's, diagnosed with Parkinson's already. In general, they may have it once a year. So, but many patients may have different kinds of progression throughout that year. And in our focus groups with patients, families, and also interviews with clinicians, they think that, well, this may actually provide us more longitudinal information that can inform care. And so that we don't have to only rely on patients when they come once a year. Now, patients did say that, well, that would be great because they have more information. But some patients, interestingly, also were concerned that, well, what if they see, you know, from our stick figures that our condition hadn't changed very much? Would that mean that they would now, instead of seeing me once a year, they don't see me for 2 years? And so now, of course, in some ways, when we think about resource allocation, we may think, well, that's totally appropriate because this patient does not, quote unquote, need the care. But the patient may not actually understand what exactly the machine learning output really mean for them. And they may still have various kinds of concerns that they want to talk to a provider. So there may be questions even coming up in some of our discussions areas, are there other ways to use the information to enhance education of patients about their progression, but doesn't necessarily mean that it will decrease their access to neurologists. Neurologists may think that, well, it would be good to have quote unquote objective information, but we may still need to actually have patients' own narratives, their own reports in terms of how is that perhaps affecting their own life, their family relationship, and so on and so forth.
Thank you. And just to kind of follow up, we have a question from the chat asking about how this would receive by perhaps patient partner groups. So going back to how patients are perceiving the use of these tools, would you recommend using patient partners at the design stage to kind of help, navigate that process?
Yeah, I think that's a great idea. Patient partners and also like community engagement, right? So one of the questions I touched on towards the beginning, when we talk about human-centered care, it's not just about one particular human or even one particular disease, right? So sometimes we also need to think about how would that be accepted by the community community of the patients with similar experience in terms of how they think care should be delivered. So I mentioned earlier mental health. There are people who would like to have mental health apps because it may be more private. They think that it is easier for them to access, particularly if they have experienced historical stigmatization. Mm-hmm. Now, in some ways, I may say that, well, it's great for people to be able to use a tool where they feel more comfortable, but it is not by itself addressing the fundamental problem that we have discriminatory or stigmatizing healthcare systems. So that tool itself is not addressing any of these other broader questions. So how do we actually redesign the system in such a way that we can have community and patient representatives to inform us in terms of why are they turning to these tools in the first place? What are some of the gaps or concerns in the system that make it harder for patients to seek care in the ways that they see best? So how would they use these mental health apps in enhancing their day-to-day care without sacrificing some other kinds of in-person care?
Yeah, I'm even thinking about like my kids, their generation is so used to having access to apps for all sorts of different things. So that might be more appealing to some of them versus maybe people who might be a little bit older and prefer, the way we did things before COVID, not on Zoom and not on telehealth and whatnot. So we have another question on the Slido, and it's, I'm curious why the COVID algorithms were unhelpful. Is that due to a lack of longitudinal data?
The COVID, right. Okay. And I see something in the chat I want to address as well. So the COVID is interesting partly because one, I think that especially earlier on in the pandemic, we didn't have all the information. So we didn't necessarily know what to look for. And also I mentioned earlier too, different hospitals may have different operating systems. The IT infrastructure may not really allow us to actually have all the data. And by the time that we have the data, we're already 2 steps behind, right? So we did not necessarily actually have the most current information. And so in many ways, and even though we have data, it depends on whether the data is actually high quality in the first place. And how were they actually labeled would make a huge difference in terms of what your output is going to look like. So if they were labeled incorrectly because we didn't have all the accurate information, that may in the end also result in incorrect, unreliable outputs. So, so there are definitely questions about the data. There are also questions about implementation as well. How may clinicians actually be able to use that? I see that Dr. McCradden just put in the article from Nature on that as well. So there is a question in the chat, if I could also respond to this, because it was a question that I was thinking about when Dr. Karim was talking as well, about how do we have potential informed consent in these kinds of studies? Is it even feasible? So one thing, last year, the topic that we were focusing on for this conference was on like real world trials. And I myself and some others from CHAOSS also talked about the messiness and the complexity of real world trials. And because one of the questions that I have too, and I'm bringing it up is not because I have an answer to it, but I think that from a research ethics perspective, sometimes we focus a lot on informed consent at the individual level. But there are questions in terms of whether we should expect patients who are seeking care to have all the data to be included in these big data sets for analysis. Because there are questions sometimes when we ask for individual level consent, especially in a tax funded system, it may sometimes mean that some patients will say no to have their data being included. But what that could mean is that we may have data sets that would be missing. It's not even just that we going to St. Paul's Hospital versus Vancouver General versus Kelowna and so on and so forth. But that even within St. Paul's Hospital, it is possible if we ask for individual level consent that some patients, maybe because of historical marginalization, systemic racism, or other kinds of isms, that may be less trusting of the system to begin with, that they would say no to any of the data being used for analytical purposes. Then you may not know whether your results are accurate, right? And because the patients who may consent to the data being shared and those who don't consent may have fundamental differences in terms of their exposure to various kinds of diseases in the first place, their access to resources in the first place. So I think that I'm raising it as a question. Consent is a big question, but I don't think that we can always only rely on consent as the main tool. Accountability of other policies, and hopefully Dr. McCradden can say more in relation to SickKids' approach to this. But there may be many other questions about community engagement that may actually address more than simply thinking about individual consent or focusing on individual consent.
Yeah, and I wonder too if it would be helpful or not if the health systems made it clear to patients that it's, you know, a learning health system and data may be used for these purposes so as to not bias kind of where we're going with healthcare in the future. But it's a very thorny issue for sure.
Exactly, yeah.
Okay, so I'm not seeing any other questions for now, but I'm really looking forward to the conversation at the end of all of our presentations. So thank you very much, Dr. Ho.
Thank you.
And we're going to switch gears and get Dr. McCradden up for her talk. And we've got, good afternoon, Dr. McCradden. You're joining from Ontario, so I guess it's afternoon where you are. Dr. McCradden is from the John and Melinda Thompson Director of AI in Medicine, Integrated Lead AI in Medicine Initiative, a bioethicist from the Hospital for Sick Children, Associate Scientist, Genetics and Genome Biology, Assistant Professor of the Dalla Lana School of Public Health. And Dr. McCradden is going to talk to us a little bit about what's going on at SickKids and their really interesting ethics review models for machine learning studies. So welcome.
Thank you so much. So hi, everybody. I'm really excited to be here to talk to you about this pathway that we have put forward. Also super happy to take questions at the end. So first, I want to acknowledge that I'm coming to you from Toronto or Takaranto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And it is now home to many diverse Inuit, Métis, and First Nations people. We are covered by the Treaty 13 territory. And I think what this means to me is particularly important because we are talking about research ethics, which is an area that has been very, very challenging for Indigenous peoples, and many of the tensions between, concepts like Indigenous data sovereignty will play into how we review things from a research ethics perspective. And so I think it's really important that we continue having those conversations about what model, how we can balance inclusiveness while also respecting concepts like sovereignty in recognition of marginalization. So the context and scope of what I'm going to talk to you about today is that I first want to make sure that I clarify that when I'm talking about this model, it refers to any AI system that is focused on making a claim to patient benefit. So the intent is to use it to affect a particular outcome, to influence clinical decisions, which might be different from something like an administrative tool or an administrative application of AI. So really, I'm talking about the cases where we want to use AI and make a claim, make a knowledge-based claim that using this AI will have ideally a positive effect on patient care. So one of the reasons that this is necessary is because while we have these regulatory structures like the FDA, IMRDF, and many other kind of groups, including Health Canada, which have provided an oversight process for some tools, it's important to recognize that many AI tools are actually exempt from these pathways altogether. And they have a very narrow focus, which is about safety and minimum efficacy. And even in the literature, there is a debate as to how much they are actually effective at determining efficacy. So really what we also need to think about from a healthcare perspective is what evidence is needed to justifiably integrate an AI tool into care. What kind of knowledge do you need about that tool in order to have a foundation, an ethical foundation on which to say, yes, we're going to bring this into the workflow and explain that decision to patients. So to try and answer this question, people have been trying to figure out what's the right framework to actually evaluate AI. And really the focus of the debate was between two paradigms. One was the research enterprise and the other was quality improvement. And it's really important that we get this right because typically quality improvement projects are exempt from independent ethics review. Even places like Sick Kids, we have some amount of ethics oversight of QI projects, but it's really not the norm everywhere. And I know from research ethics folks that this is like the #1 question that they get asked. So we'll spend some time chatting about it. So when we're defining research, research is the idea of testing hypotheses, contributing to generalizable knowledge. That's from the Belmont report. The Common Federal Rule in the United States says that it is a systematic investigation, again, pointing to this idea of generalizable knowledge. A Tri-Council policy in Canada has taken a different route with the intent of including things like qualitative research and narrative methodologies, which don't necessarily aim for generalizability, but what they are trying to do is contribute to a knowledge base through disciplined inquiry. And so they might use a set methods to do so and to test hypotheses as well. So quality improvement is different because this is a systematic and data-guided activity that's designed to bring about immediate positive changes in the delivery of healthcare in particular settings. And there's a few myths that come along with QI. So QI is not universally low risk. It's also not always exempt from requiring informed consent of participants. It's also not less important or less impactful. You are still able to publish. And it's designed to optimize the delivery of established clinical interventions. And that's really the important part because the justification for that lower level of oversight of QI activities is because the intervention itself is known to be in patients' best interests. You can think of hand washing as a good example. We don't need to do an RCT to know that hand washing is effective in preventing infections. And so we might have particular activities around the frequency or intensity or length of hand washing, sanitizer versus soap, which wouldn't require a full research paradigm, but can be used as a QI initiative. And so the question is whether machine learning is QI. Machine learning models don't necessarily generalize to different sites. Some of them are explicitly designed not to generalize. They are intended to optimize the care of individuals downstream. And they're validated through an iterative process and not always a strict protocol, at least when we're talking about the development of a model or running a silent trial. They also don't independently change the interventions themselves. So in contrast with something like a drug, where you're introducing something into the care of that patient, machine learning models don't independently introduce something novel into care. And typically they're believed to be low risk, which is increasingly in question in light of many of the papers that have come out lately. So could they also be researched though? And so one of the common things that people will point out is that the approach to model development might be generalizable. So sick kids may have a model that is designed to detect cardiac arrest. That model itself, you couldn't actually transplant and put it at, BC Children's Hospital. But by following the process that we use to develop that model, you could develop the same kind of model. Machine learning work also does involve systematic inquiry. So although it is not as rigid as certain traditional statistical methods, it does involve a systematicity to how they test different hypotheses within the data. And then the model use itself is a deviation to varying degrees from standard practice. So they tend to constitute a novel intervention within the care pathway. And it's really important because we're starting to recognize that there are, both direct and indirect risks that can be presented from using a machine learning model. And so now it's pretty commonly acknowledged that we don't necessarily know what the effect will be of using a model in clinical practice. And so although it doesn't independently introduce something different into that care pathway, it can prompt a patient to receive an intervention that they might otherwise not have received, which can have varying degrees of risk depending on the specific application that you're talking about. So for instance, if we're trying to optimize care delivery within the emergency department, there would be a really big difference between a model that predicts whether a patient is in need of a X-ray versus a model that predicts whether a patient is in need of a lumbar puncture. So there might be different risks to the different models that we're using. Now, people often talk about the AI chasm. There's the statistic that I think 0.001 of models are translated into clinical practice. One of the reasons is that this is kind of an unfair analogy. So a lot of the models that we're talking about are developed in an historical data set. And so that means the outcomes and exposures are already done. This is a completed case. And so you can clean your data, lots of pre-processing techniques, explore that data and develop a really robust model that might generalize, to a certain extent. And so the thing is, actual clinical practice looks like this, where it is messy. There's a lot of noise within the data, and we're dealing with patients whose exposures have not yet happened and the outcomes are not yet certain. And so people are trying to figure out how exactly do we bridge that gap? And it's an important question because we operate within the paradigm of evidence-based medicine. And so sometimes when we talk about AI, there's sort of a way that AI seems to kind of take over everything that's within this hierarchy here. You hear people talking about, does AI override clinical judgment? Does AI override patient values? Is AI the sole source of research evidence? But really, when we look at this paradigm, all of these things together form the basis of evidence-based medicine. And so we need to be precise about where exactly AI contributes to this picture and how. And so that's why we're talking about what kind of knowledge we can generate about the efficacy of an AI tool. So back in 2020 in September, the clinical trial guidelines for AI, Consort AI and Spirit AI, which I participated in, came out. And this was largely in recognition of the fact that predictive accuracy does not translate directly into patient benefit. Dr. Ho gave a number of really great examples of this. There's many of them. There's a couple systematic reviews out now as well, which show that, through prospective evaluation, around 2/5 of models might actually work in clinical practice. And that might be based on, the ones that are really, really robustly developed. And so the other concept that's relevant here is duty of care. So when patients come into a hospital, if they are subject to an intervention that is part of an experiment where we don't necessarily know whether or not it works yet, the duty to care applies. And we do have this distinction between research and practice because patients should know when we're testing something versus when we know something is going to be effective. And clinical research is subject to REB oversight. And so we ended up developing this pathway through Sick Kids that was overseen by the REB that was adapted to suit the specific needs of machine learning applications. And so it has 3 stages here. The first stage is exploratory. So this is where a team might be developing a model or trying to identify which models might be candidates for clinical translation. And so we made a number of changes to the typical pathway that you might use for access to data as part of a secondary use protocol. So rather than the project-specific model that we typically have, we said to teams, okay, if you're a team that's working in the emergency department, you may want access to all of the data sources within that within the emergency department. So it might include imaging, triage notes, EHR history, etc. And so we have said that it would be okay in this case to not have a really specific goal. So we're not going to have the team say, we're trying to predict which patients are going to need emergency surgery. And the reason for that is because when you set out with a predetermined goal that you're trying to predict, it can influence the researchers to try and develop methods to specifically suit that goal rather than having a more open hypothesis testing. And that's important because, again, when the researcher is trying to move toward a specific goal, it can influence them in certain ways to try and achieve that goal. And this is typical of most statistical techniques. So we've allowed them to be a little bit open about that and to look for models that may be potential candidates for translation. We've also allowed for researchers to have frequent data retrievals, sometimes as frequent as 5 minutes, and we are hoping actually to move that up into real time. And so that also allows us to make sure that a model, one of the ways of generalizing a model is beyond kind of this initial test set. And so you might want to generalize across time, you might want to generalize across contexts. And so the frequent retrievals allow us to do that. So it's on the PI to keep accounts of who is working on which data sets. There was a question earlier about de-identification, and that's one of the things that, I think like many folks, we continue to struggle with. Within our framework, what ideally happens is a member of the team who is not working on some of the model development is the one who is ensuring that de-identification is properly conducted. And so through using that method, we try to separate the research from the de-identification process. So the second part of this is that once you develop a model that you think can have some clinical applicability, you would then run it over a silent period or silent trial or shadow trial. There's a number of terms for this. Essentially what this is the model is integrated into the clinical workflow in which it is intended to be used. However, the predictions do not go to the clinical team. They go to the research team. And so the research team keeps track of the model predictions and also keeps track of the eventual patient outcomes to verify, did this patient actually, need what the model predicted or have the condition that the model predicted? So in the example of surgical outcomes, you would be looking at whether the model predicted if this patient needed surgery. You'd be looking at the longitudinal outcomes to figure out how many patients who were predicted to need surgery actually did end up having surgery. And so through that, you develop a sense of the clinical accuracy of the model. It's also really important because we know that in silico performance means very, very little prospectively. The silent trial is actually the ethical justification, not just for clinical integration, but for proceeding to a randomized controlled trial. And because we have this concept of equipoise in clinical research that typically underpins whether or not you can do an RCT on something, we think that the silent trial can contribute to that by actually destabilizing the current standard as the superior option. So this idea basically is that if you are going to do a research trial where you are exposing participants to an experimental treatment, that you should have some reason to believe that that experimental treatment might be better to the current standard. And so the silent trial really gives us a stronger foundation to say the model's performance has been this accurate on a prospective clinical population. Therefore, we think there's good reason to believe that it might be better to standard of care. So there's those two goals. There's the model validation, so making sure that the model is actually going to work prospectively, and then the clinical evaluation. So you're assessing the clinical performance. And a really important part of that clinical evaluation is the fairness components. So you might make a number of different choices, design choices about your algorithm in the first stage. But really the important part is that you want to test whether it is going to work for all patient populations. And so not only are you looking at clinical accuracy overall, but you might be looking at clinical accuracy among different medical, clinical, or demographic subgroups of patients. So once we have a model that has passed certain thresholds for a silent trial, and we're now ready to proceed with evaluating the impact of that model on care, you would move into a clinical trial. And this can be, there's a plethora of methodologies that are available all the way from observational, pre-post design, quasi-randomized, stepped wedge, pragmatic, randomized controlled trial, you've got them all. Really, it should be suited to the specific question that you're asking. So if it is something like, you know, again, that example that I gave earlier, if you are looking at predicting which patients might need an X-ray and sending them to get an X-ray before they actually see the doctor, that is a very different level of risk than if you're predicting that they'll need a lumbar puncture before seeing the doctor. And so we might have different levels of oversight in that case. The knowledge claims are also stronger. So some models say that they are contributing to a larger decision-making picture about a patient. And so they might be one piece that a clinician takes into account when making a care decision. There are other models that purport to be automated, and so they take over a certain aspect of that care. And so the models that make the stronger epistemic claim should be subject to a higher degree of empirical rigor when we're designing trials. So again, one of the important things in the clinical trial too is this disaggregated model performance. And this is something that was part of the reporting guidelines for clinical AI trials, which again is really important to these concepts of patient safety and justice, so that we know that we have guidelines for how to exactly use a model depending on the patient in front of us. It also prioritizes clinically relevant evaluation. So something that you might hear a lot is that one of the most commonly cited values in machine learning research is the ROC. And that's not a metric that means very much to clinicians. And so this prospective step really is focused on providing the kind of information that clinicians need to help them make decisions about how to use a model. So for instance, if it's been evaluated in pediatrics, if a model was, used at sick kids over a 6-month period, and by using that model, we saw more children receive tests prior to seeing the doctor, which decreased their wait times overall, and we had no adverse events from that study. That might then say to another site, if you follow this process, and this is how you develop your model, and this is your general accuracy on it, and this is how you use the model, you also could have those outcomes. So we sort of tried to integrate this into the pyramid for evidence-based medicine to consider what the different levels of research might provide to the overall picture. So these retrospective studies, that's the in silico validation, where you're developing a model, and this offers some theoretical plausibility that a particular patient condition, outcome, or et cetera, can be predicted using machine learning. When you have your silent trial, this is essentially a prospective observational or non-interventional trial, and it's descriptive, so it can't establish facts about the model's impact on a given outcome, but it can provide us with a sense of clinical accuracy. We then have quasi-experimental trials, which involve non-random participant selection. They're very practical, and they can be used when it's too difficult or unethical to do a randomized controlled trial. And so they can be very systematic, and there's a lot of work that looking at estimating causal effects from these sorts of trials, but they are susceptible to certain biases when you compare them to a randomized controlled trial. And so the RCT, as everybody knows, always kind of sits at the top of the pyramid. And so particularly when you're making a strong knowledge claim about a model, an RCT might be the preferred design in that case. So I'll go back for a second just to mention there are now these 3 guidelines to help with this prospective phase. So if you look at Decide AI, for example, this is a first in human, this reporting guideline refers to first in human trials or pilot trials. And then Spirit and Consort are protocols for controlled trials and trial reporting. And so when you look at those, when you look at the items on there, it's really helpful from a research ethics perspective in looking at what things you want to be looking for on an application to the REB when it involves a prospective study of an AI system. And so we've sort of looked at how this fits in with other frameworks. So there's the drug development. We've looked at AI in healthcare and then compared to surgical innovation. And so you can see there's the preclinical development. Tripod AI is a reporting guideline for predictive models. You then look at the safety and efficacy or small scale, which is akin to phase 1 or phase 2 trials. And you've got Decide AI right there in first in human. And then when we're looking at safety or efficacy or large scale trials, then we're moving into Consort AI space. And that 4th stage, post-market surveillance, there is a analogous term in AI, which is algorithm of vigilance. And quite frankly, this is something a lot of people are working very hard on and no one has really figured out quite yet. There's a lot of issues like data set drift that we have to be mindful of, and a lot of great work in this field. So this is something that a lot of folks are working on. And so overall, what we're hoping is that this sort of paradigm can better align us with an evidence-based model of care and start to provide the kind of information that is really relevant for clinicians in trying to determine whether, when, and how to use an AI system in clinical practice when they're trying to influence patient outcomes. So with that, I will say thank you. This is my contact information and looking forward to your questions.
Thank you so much. That was very fascinating. I'm curious if you could maybe give us some insight on how the researchers at SickKids have responded to some of the protocol guidelines that you've set forth for them for the ethics review process.
Yeah, that has actually, so we've had a little bit, it's been since January 2020 that this model, review model has been in place. And so I think once folks realized the amount of freedom that they can have in exploring data and the ability to have that under, a solid legal framework, it has really facilitated a lot of exploration. I think at last count, we had almost 30 data access protocols across the hospital. So this is corresponding to like entire departments that are doing AI. And there's really been a lot more freedom of exploration for them and really clear rules as well as to like, how do you access data, who gets to access data under what purposes. And additionally, a number of the conferences where people are now publishing are requiring an ethics statement for how they got access to a personal health information. And so our researchers have been able to say that this is an REB approved study. It's still like very much an iterative process. So particularly with respect to the silent trial. So that had sort of started off as just a way to establish whether a model was going to retain any sense of technical accuracy in the clinic. And as we've seen teams go through these steps, they've actually want to freeze. Oh. Am I back? Sorry, I think I froze.
Oh, you're back now, yeah.
Okay, sorry. Yeah, so as teams have kind of started doing more and more silent trials, they've started integrating many different knowledge sets into this. So for example, we have a lot of human factors expertise now being integrated into the silent trial. We also have human computer interaction. So this is testing different ways of visualizing the predictions from models, because one of the unique risks in this context is automation bias, which may or may not actually be made worse by certain forms of explainability. And so what we're trying to do is actually test that. Do certain forms of explanations actually bias people to accept incorrect predictions, and which ones are linked with the most appropriate use of the AI tool? The other opportunity that's increasingly coming into the silent trial is patient and family engagement. So our Children's Council is really, really interested and really, really engaged. And so we've started bringing them into earlier and earlier conversations about how we should do trials, how we should develop the model, how we should integrate the model. So that piece is really kind of expanding and is very much in flux. And then we have now, it was like we had nobody who was quite yet at stage 3. And now I think we have like 6 or 7 people who are doing clinical trials. So, or groups that are doing clinical trials. So it's really expanding. We've created a 3rd panel of the Research Ethics Board specifically to oversee these studies. And the work is growing.
Yeah, that's a lot since 2020. Like, it really speaks to the kind of program you guys have put in place. Just for my own knowledge, you guys have like a training program for to help other REBA or reviewers kind of learn how to review in the framework that you guys have put in place. Uh-oh, did we lose? It's frozen again. Oh. All right, so maybe we'll table that question until
I'm back. Sorry.
Oh, are you back?
Yes.
Did you hear my question?
No, I don't think so. Sorry.
I was just curious for my own knowledge, if you guys have some sort of training program that you can help other reviewers and REBA kind of learn how you guys have put this in place and how to review in the way that you guys have going, because it sounds like a really successful program.
Yeah, it's still growing. Honestly, we're going to have, we're trying to think about what training materials would be valuable. I think mostly we've been thinking about what kind of expertise we need to have. So we've got a number of machine learning researchers who are part of the REB now, who can help with the science review components of this. So we have kind of some training materials. A lot of it is really about like, what's the process here? And then the other kind of component that I think, there's still a lot of thinking around is this fairness aspect, because machine learning researchers, there's a number of tools and applications that they might utilize to influence a model's performance in a way that might be complementary to goals like equity or equality. And so thinking about how we evaluate those, not just from a technical perspective, but from an ethical perspective, is something else that we are still kind of working on developing.
Great, thank you. We've got a few questions here. So Dr. Ho's asked, with the 3rd panel, are there specific, she asked about the specific areas of expertise, which I think you just covered. The next one, it seems that a new process supports clinical decision-making. Are any of the machine learning projects directed at supporting patient decisions for self-care? That's actually a really interesting question.
Yeah, that is a really good question. I think that the closest that we come is to helping patients assess the risks a little bit better or a little bit differently. So typically, it would, like, the paradigm we often think about is like the clinician will kind of tell the patient what their impression is. And so in some cases we've thought about whether you might actually kind of use the model prediction that might go directly to the patient, who might then, with sufficient support and education from the clinician, might be able to kind of integrate that assessment into their own risk analysis. So one of the projects that's ongoing, it's a model that is intended to address what's called hydronephrosis. So this is a condition where a pregnant person will come in for their first, ultrasound or something like that. And there will be an initial scan, and you may detect hydronephrosis at that point. If that pregnant person, if that's detected in the fetus, then the pregnant person will come up for multiple follow-ups throughout the entirety of their clinic visit. But ultimately, only about 50% of those individuals actually have a baby who then requires surgical intervention. So the idea with this model is that by predicting from the first ultrasound who is likely to need who is likely to need surgery down the road, the goal is that you would only have the people who actually need surgery coming into the clinic, and that the folks who don't end up needing it, they're the ones that if we detect early, they don't have to come for all those follow-up appointments. And so one of the thoughts is, how you would integrate that assessment into the clinical decision-making. So it might be someone who is really worried about their pregnancy, might have other risk factors. And so a clinician might be able to say, look, the model prediction is that you're very unlikely to need surgery. Given that we know it's still a possibility, that person might then be able to kind of think about their overall context, and make a decision for themselves if they would like to kind of go with the current standard care pathway.
Great. We've got another Slido question. Given the limit of algorithms, do the models take into account the risk of unintended consequences or unexpected adverse events in the RCT phase?
Yeah, so ideally when you're getting into the RCT stage, you've got a model that is, for lack of a better term, like locked. So you've tried to account for those things. When we're talking about an RCT2, like the adverse effects or the potential harms, ideally will have been specified a priori, so that the clinicians who are using the model and the patients are consenting on the basis of knowing the likely risks. Typically, when we talk about the design for the RCTs, we're trying to do what we can to ensure that a patient who is potentially receiving an AI intervention, at the very worst, would receive standard of care. So in the example for the emergency department, one of the goals is to identify which patients, when they get to triage, what tests are they likely to need, so that if we have a machine learning medical directive that indicates that this patient is likely to need a CT scan or an MRI or a blood test, they can go do that before they actually see the physician. And so the alternative to that is that, they wait around to see the physician then assesses them and orders the tests. And so that model really specifically needs to be calibrated so that there are no false positives in that case. So there are no patients who are getting an unnecessary test that we're erring on the other side of risk, which is that a patient may wait longer who could have had a test earlier. So it's really kind of model specific to that. And I think that as we get more and more examples, we'll get more and more sophisticated at being able to think through that, because really, honestly, like it's kind of one at a time that we have to think about it.
Great. So maybe now's a good time to bring back all of our speakers, because I see that the only question we've got left is the one that came up earlier. And that was, are there ways to determine the appropriate size and characteristics of data set for a machine learning model to properly, ethically analyze and answer research questions? So maybe the three of you, if you guys wouldn't mind discussing your thoughts on that, that would be great.
Yeah, I can start, because I'm part of, there's a group, it's called the Standing Together Initiative. It's funded by the NHSX in the UK. And the idea of that project is to define a certain standardization for characterizing data sets. So you have examples like data sheets for data sets, which was pioneered by Timnit Jabru. There's a health sheets for data sets example as well. And so being able to do that would allow for the characterization of data sets along a number of different parameters. I think one of the only things as we do that, and I do think that that is very important, it is also important to resist some of the sort of biological and physiological determinism that can come with that. Because sometimes when we're talking about, oh, we need to test this on diverse populations, it's sort of predicated on the assumption that there might be a biological or physiological difference that is relevant among those populations. And because we know that race is not a meaningful biological construct, we need to be really careful about what we're actually trying to assess when we're talking about inclusivity in those sorts of situations.
Yeah, I can go next. I think whenever we are talking about sample size and all that, statistically speaking, obviously we can try to determine a sample size based on the research question that we have and the type of model that we are using. That's not necessarily the issue. The issue here is when we are trying to speak about ethically analyzing, we are probably, and this is my guess, we are probably trying to think about whether the diversity of the population is representative in the sample that we are capturing. Of course, one of the ways we can try to think about this is some sort of stratification based on, say, for example, if we are thinking that the people who are, say, for example, in a lower socioeconomic status versus the highest socioeconomic status, whether we are capturing them in a equal format or whether we are not getting them in a equitable format. We can obviously try to understand, and this is going back to what Dr. McCradden was saying, is that we can try to understand the characteristic of the sample, and we can try to understand the characteristic of the target population that we are trying to think about, and we can try to understand whether there is any difference that we are seeing in those type of characteristics in those type of sample and the population. Other than that, I think, so for example, if we certainly know some parts of the populations are less responsive to the questions, and we know that they're responding less. One of the ways that survey sampling statisticians do is oversampling that particular population when we are trying to get that population. That could be one way to try to mitigate this bias to some extent. That's my thoughts.
Yeah, I don't have a lot to add to what I had said earlier because I'm not a statistician. I always turn to Dr. Hubert Wong from CHAOS when we have these questions. And one of the points that he would often make is to really look at how different are the populations that we are looking at, right? So in terms of sampling, to see, if you do have a much more diverse population and you may have different population groups, then you may have to have a bigger sample. But of course, and I think ethically speaking too, with what Dr. Karim was just saying, that we do often want to have a bit more of an oversampling, just in case. But of course, at the same time, there are also other resource allocation questions as well. And we want to use, ethically speaking, we don't want to overly oversample people, because especially if people may be exposed to various kinds of potential risks as well. And so I would generally say that make sure that we have a statistician to work with you and figuring out the ICC before you can see how much differences there may be if you have different clusters and different populations that you're sampling.
Great. We have another question from Slido. On average, how large is the type 2 error in these models? I don't know if any of you would have an inkling on the answer for that one.
These models at the stage of in silico validation or like prospective performance?
I'm not sure if the poster could clarify. Maybe we could revisit that one.
Sure. I would suggest if the poster is interested, Gary Collins' work is really, really well respected in this area, looking at that sort of question.
Great. Thank you so much for that resource. Just going to write that down too. All right. So we do have another question in the Zoom chat. It says, if we look at the full spectrum of research review process, what do you perceive as the relative roles of funding methodological reviewers, the REBs, the peer review process, and the discussion of AI-related research?
I can have a go at that one, I guess. I think actually, so one of the components of that question was the methodological review. And I think that that's actually something that we should have a stronger role for in many of these, in many of the studies and grants and evaluative schema, because there's been a number of comments about in the academic literature about integrating machine learning methodologies with established methodologies from a clinical research perspective. So even the question of looking at like silent trial performance, when has it met a threshold and how did we define that threshold? That's a methodological question. And sometimes, you know, there's different practices and people will say, well, it has to be better than the standard, but then we haven't really reliably characterized the standard. And then again, like what are the risks? So every single prediction that we have is going to be accompanied by an error margin. And so establishing when that error margin is, you know, at an acceptable level. They're normative questions, but they're also statistical questions. And so some of the folks who work in methodology are really good at kind of elucidating those kinds of issues.
I think, I mean, one of the things I should say, if I read the question properly, if we are trying to determine the role of the, say, for example, any kind of peer reviewers or in trying to identify how the AI research should be evaluated, if you look at even in the academic literature, many of the research is based on just remove logistic regression and impute method X, right? And like how is that useful, and whether when we are just replacing one method to another, are we operating under the same assumptions? And sometimes the practitioners who are using these methods do not necessarily understand the implications of changing the methodology. And I generally would prefer to have at least one collaborator who knows about these, or even in the review process, having one reviewer who has some knowledge about the potential implication of replacing these.
One of this may be a minor point, but it has been a point that has, you know, concerned me. So when we think about even like RAB reviews and funder reviews, this only applies to certain subset of AI development work out there. And so AI technologies that are being developed by corporations that are not getting funding from the Tri-Council are not involving academic researchers that are in institutions that are being guided by the Tri-Council policies, may not even be going through all that review. And so, and I think that especially when we think about healthcare institutions possibly using algorithms from these vendors in particular, that we may have to be even more careful who had actually reviewed the methods and error rates, and how did the threshold, as Dr. McCradden was saying, how did the threshold about acceptability get decided? Did they have a silent trial? How long was the silent trial? What was the information? And so I think the transparency in those situations would be really important as well for one, clinicians who are going to be asked to use those algorithms to know, are they going to be comfortable using them? And for patients and who may be the ones subjected to these technologies as well.
Yeah, that's a really good point. And I want to add to that too, because I think I'm seeing increasingly collaborations between, private companies who are developing AI tools and hospital centers, where it's similar to, if you have a pharmaceutical company that develops a product, they need to test it somewhere. And so they might do recruitment through a hospital-based setting. And so then they're falling back under that tri-council policy. And I think that has certainly for us, it's been a helpful tool, because I think just, the same way that we kind of control relationships with independent companies, somehow AI has been exempt from that in a lot of respects. And I think that this, again, it gives us ground rules to set up those relationships so that we can, take advantage of tools that are proved to be beneficial, but also balancing against patient protection and also helping the researcher navigate that kind of complex competing interest territory. So I hope to see, I hope to see more of that going forward, because there's some nice examples. Actually, the IDX Pro is a good example of that. And the team at Hardy & Health also has some really good examples of collaboration between industry and healthcare settings.
Thank you. I don't see any other questions coming up, so I don't know if the panelists have any questions for each other or any kind of niggling thoughts that you guys would like to discuss in a little bit more detail. So I'll just open the floor.
Can I have just one question to Dr. McCradden about the broad goal that you were talking about? And I come from a statistics background, and whenever I see people talking about exploratory goals, sometimes I'm a bit afraid, like, what is it that is going on here? Could you explain a bit more, like what you were talking about?
Yeah, no, that's a really good point. It has colloquially been referred to as a fishing expedition. So the reason that we did that was because the way to enter the REB pathway previously was that if you were going to do this sort of study, you would have to say, we are aiming to develop a sepsis prediction model in the emergency department. And one of the things that we now understand is, like, you don't necessarily know that you can actually do that. It may or may not be a thing that we can predict given many different things, right? And so the kind of open protocol allows for not pre-specifying what outcomes you're going to study, and instead allows them to explore the data toward many different aims, test those aims, and to see if there's a potential candidate for translation. So that does have to be balanced against, principles like stewardship and preventing research waste. And so that's something where there's sort of the tension between, like a basic science perspective where there is scientific inquiry for the sake of scientific inquiry and knowledge generation and all of those things. But our kind of AIM institution is an explicitly translational enterprise. And so in one of our kind of guidelines for folks, we take a little bit more of a stance to say there are certain things, certain ways in which you should or should not go about developing these models. And that's something that we're actually kind of actively working on. Dr. Karim, I don't know if you're familiar with, there's the AI Mad Libs that Corey Shivers kind of publicized. It was, if I knew X, I could do Y, as sort of one of those starting steps to developing like something that is actually going to be clinically meaningful. And then we're trying to incorporate a number of practices from like design thinking and change management to try and help people more efficiently kind of narrow down on the types of models that they're going to develop. But that's sort of within the explicitly translational umbrella, whereas some folks who are on the basic science research side may have different sorts of goals.
Thank you.
Just going to interrupt for a moment here because I see Elizabeth got her hand raised. Elizabeth, did you want to jump into the conversation?
Hi, thanks. I actually had a question, and it's open to all the panelists, but it is about artificial intelligence. I just remember reading a long time ago, well, actually not too long ago, a couple years ago, I think back in 2018, 2019, it was a study done in the States about how AI was reading ultrasounds, and it found to be more accurate at determining like breast cancer than actual radiologists. And I found that an amazing research study because it resonated a lot with me, because I became a patient once, and I had a kidney infection, like pyelonephritis. And because of the ultrasound report said everything was negative, it directed my treatment, and it took many months for them to diagnose me because the ultrasound kept saying negative, negative. Well, it was just one report, and it turned out that radiologist misread the report, and I had an infectious disease specialist look at the ultrasound directly and said, yeah, you have pyelonephritis. And so it was like, you know, I've had my ultrasounds misread, and when I kind of and it actually caused undue suffering to me, invalidation of my symptoms and my suffering. And it took a much longer time for me to get diagnosed. It actually took like 2.5 months. And in the meantime, I was having like night sweats, fever, tons of pain. I was on disability because I couldn't work. And so I'm just wondering, like, what do you think it would take for health authorities to start adopting something like this, like AI, that is actually found to be more effective and more accurate at diagnosing things on ultrasounds? Because ultrasounds are really, really tough to diagnose. And it's really, when you look at an ultrasound, like, you don't even know what you're looking at. And I know AI is, they're programmed to learn patterns, and they can like make their decisions. And I just found that was so incredible, and it resonated a lot with me because it really affected me directly, that this mistake on that radiologist, misreading it as like, your kidney was normal when I actually had like inflammation, fluid around my kidney. And if an AI just quickly read that report, maybe that wouldn't have happened to me. But I'm just wondering, like, what would it take for a health authority to kind of start adopting AI into something like diagnostics? Because I just see that we're really far away from that, and I don't see any integration of AI into healthcare, but I would like to see that. But I just see there's a huge barrier, and I'm not really sure what those barriers are. So I just was wondering if you guys had any insight or thoughts of how we can get there.
So I'll start by saying I'm really sorry to hear what happened to you. That sounds really, really difficult. And I totally agree that it's important to try and figure out what sorts of technological interventions can help prevent situations like that. With respect to the performance of AI in situations like that, unfortunately, nearly all of those studies are based on the performance just in an historical data set. And so we don't always know if it is actually better than a clinician in practice. So one of the ways that has been tested is the model will kind of do a prediction, and then a radiologist will check the prediction. But when we're working in real time, like is the case with actual patient cases, we have to be even more careful that we don't end up replicating those sorts of mistakes. And so I think that, to your point, one of the things that I think can help institutions adopt beneficial technologies is to really prove that that's the case through prospective studies rather than just relying on the retrospective ones. And I very much hope that we can use AI in that way to prevent situations like the one that you experienced.
Yeah, and to add to what Dr. McCradden just says too, because probably it would take some time also just to make sure that it really does work for all different patient populations. And so I'm not saying that this is particularly about breast cancer imaging, but for example, that there have been studies that show that dermatology reports have been more accurate when it is on patients with lighter skin. And so that if unless we have actually tested them in different settings with different populations, we wouldn't know for sure that it actually is accurate across all populations. But assuming it is and has been tested and gone through rigorous clinical trials, and then there may be questions also going back to something that I mentioned briefly in my presentation. How does that fit into the clinical workflow? Right? So Dr. McCradden already pointed, are we using that as a, is to enhance care, to enhance diagnoses, or is it to replace? And so there may be questions in terms of how do we adopt any kind of particular technologies, especially given the way that we also are using electronic medical record. Would that speak to different other parts of what clinicians are already doing?
Yeah, I mean, obviously this is a very painful experience. I'm sorry to hear about this, but I agree with both of these panelists that I think obviously we have made some progress, but we are still probably not at that stage to be able to completely rely on the machineries. Having said that, I do recognize that it is still possible to some extent, as Dr. Ho said, that in some of the clinical scenarios, these models are probably more reliable than the others, and probably it would be better for us to think about ways to try to not replace, but at least at this point, having both of these opinions and try to figure out how we can integrate both of these and make a decision.
I appreciate your answers, and I totally agree that we do need more research. And I'm a research coordinator here at Kelowna General Hospital, and I do hope to see more like artificial intelligence involved research studies in the clinical environments. I really hope that one day we can bring that on board here and start, collecting evidence and then also trying to map out how that will look like, and because it does resonate really closely to me. And I know the United States, that was like a study from the United States, and I think they actually did compare it to radiologists' reports, but I just don't know how far they went with it. And again, it was in the United States. But so yeah, I really look forward to more of that kind of research here in Canada. But thank you so much for your answers and your presentations. It was wonderful. Thank you.
Thank you, Elizabeth, for sharing your story with us. We do have another question in the chat. So to extend the earlier question on what changes are needed to the current TCPS to address the developing AI research activities, I think that's a really, really important question. Anyone want to take a stab at that? Even if anybody in the audience knows if there's been any discussion with the tri-councils about how to approach this, or.
Yeah, I mean, as I have mentioned earlier, I'm not an ethicist. I probably know the least about this. But one of the things I should say that I was very encouraged to see Dr. McCradden's presentation and the ways they were justifying the broader goals and explorations. And I generally think this is also relevant for any type of research. When we're doing our research based on our prior experience, we are just setting up an outcome that we think are going to be useful. But in reality, when we are dealing with the data, we are seeing a different reality, and then we are doing post hoc analysis and all that. We could avoid all that if the researchers were probably given a bit more freedom to do a bit background study. Yeah.
I can make a very brief comment. So the chapter 2 of TCPS talks about the scope and approach of the Tri-Council agency in thinking about review of different research studies. And I think that, as Dr. McCradden was talking about too, that there are questions in terms of what are QI projects, which generally don't require research ethics review versus specific research projects. And I think that we may need some clarification in terms of some of these technologies when we are introducing technologies as quote unquote part of operational decisions. Sometimes there is a really blurry line between what is QI and what is REB, what is research that requires REB approval. And I think that if we rely everything on RAB approval, that we're not going to be able to then catch, I think, some of these mistakes early on. And so there may be questions in terms of whether we have to have other kinds of processes in thinking through, even thinking about what kind of tools we want to develop for the hospitals, and whether that distinction between QI and research, particularly when we are aspiring to be learning health systems, is actually the most helpful distinction.
Yeah, I would agree, because I think it can change even within a single project and over time. Like, just as an example, in the intensive care unit, we were developing a model that was basically, it was part of a larger approach to detecting clinical deterioration. And so the thing is, when you are a patient at the bedside and you have a central line, each time that line is accessed, it produces a very distinctive symbol within the physiologic waveform data. And so one of the models that the team here was developing was actually just to detect that signal. And so that's not influencing patient care. It is not something that is, independently contributing to decision-making. It's just the annotation of that. And it would automate a chart entry for a line access, because right now, the way that would be annotated in the chart is that the nurse would chart it physically themselves. And that's challenging because nurses are the hardest working people in the hospital. So they don't have a lot of time, and they often are doing it after. And so that sort of automated annotation would actually help with that. Now, that being said, the team then also said, well, what if we could look at patterns in line access and see which patients develop a hospital-acquired infection? Because we also know that line access can contribute to risk of HAI. And so then we're like, well, is that a research question? Because you're testing a hypothesis. Can this model accurately, are there patterns in this model that can actually detect who's at risk? And then you might try and evaluate that prospectively. So if the model is detecting particular patterns and flagging patients who are at risk, could you actually use that to optimize line access in terms of medication delivery? And so then even that, which started in the QI space, got into like a weird gray area, now is actually going to be part of a prospective trial. So it really depends, on the knowledge claim that you're trying to make. If it's something where we're using something that we already know works and we're trying to optimize around that delivery, we're not kind of producing knowledge. I would say this new thing is going to help us better care for patients by improving outcome Y, but can do this other thing. So, and I think that the other part of it too is that even if we do move a lot of these to QI, most institutions do not have any sort of ethical oversight system for that. And so we need to be able to flag risks to patients through a QI process. We do need to be able to have a science type review for the validity with respect to the methods that are used. And we would still need to have a process for assessing the fairness parameters of that application. So yeah, I think there's a kind of a lot to work on in terms of the scalability of this process.
Thank you. Those are great answers. We've got another question that's come up in the chat. I've been learning about AI and robotics in manufacturing, and the thinking about this is an integration of the technology with human assistant procedure works better than an either or approach. I think this kind of thinking will be needed in the integration of these technologies into clinical settings. You're optimizing processes, really. What are your thoughts?
There's an interesting study. It was 2019 in Nature Medicine, Chandel et al. And it was a system that was designed to detect skin cancer. And so overall, there was a beneficial effect of the use of the AI tool. However, when the AI output was incorrect, clinicians actually made worse decisions than their initial correct judgment. And so this was evident across the spectrum of experience. And there's a more recent follow-up study, Marzigasemi and colleagues looked at patterns of how clinicians use particular explanations. And they found that there were some clinicians who rejected all incorrect predictions and others who accepted all incorrect predictions. So I totally agree with this comment, because I think the human-computer interaction component is probably one of the most critical things that we need to study so that we can figure out how to have the best possible balance between those two components.
Thank you. Do we have any other comments on that from our panelists? No? Okay. Again, oh, sorry, Dr. Karim, go ahead.
No,
Oh, yeah, I
just-
thought you unmuted there.
I was just going to say that I mostly work with tabular data, not the type of imaging or computer-assisted process that the other panelists are probably more familiar with. But having said that, I think I do agree with the comment that Dr. McCradden has made about needing more research into trying to understand not only the output of the computer-assisted process, but also how the clinicians are taking that into consideration when making their decision. So this is obviously in progress right now.
I'll make just a very brief comment. I haven't seen that article, so I would love to look that up too. In terms of whether, because there have been certainly broader ethical questions and methodological questions too, whether as we rely more and more on technologies and their outputs, whether sometimes that we are questioning these outputs less, right? And there may also be, I'm between, US and Canada, there are also questions about liability that sometimes that we may be concerned, as Elizabeth Betta was pointing out this, in her painful experience, that sometimes we may ask the question in terms of whether somebody will have to have other AI outputs to back up their clinical recommendation. And so there are certainly going to be questions too in terms of how do we use these technologies. And if it is the case that clinicians have different judgments, would they feel free? What would be the process for them to be actually challenging that? And similar questions can be asked if patients also have questions or concerns about the output from the AI algorithm. Could they also challenge that?
Yeah, I think the liability point is very important here for any health authority to authorize any machine learning methods to be integrated within their clinical decision-making system.
Thank you. So I'm just mindful of the time here. We've got about 2 minutes. I'm not sure if any of you have final thoughts you'd like to get out to the group before we say our goodbyes. No, if not, thank you all. This has been so fascinating, and I feel like we could probably keep talking for another few hours about this topic. We greatly appreciated your time to join us today and speak to our community. And thank you to all of our members in the audience that joined to hear this. It was a great session, and looking forward to the one this afternoon as well. Take care, everyone.
Thank you.
And thank you all.
Thank you.
Thank you, Sarah, for being a wonderful moderator. So that brings our first session to a close. Thank you all very much for joining us today. And we'll see most of you back this afternoon at 12:30 when we'll have our next session on Beyond the Binary, talking about gender equitable practice. So looking forward to seeing most of you again this afternoon. Thank you very much.